Good afternoon, everyone. I am Chris Sorchik. I'm the Executive Director of Capital Area Healthy Start Coalition. Welcome and thank you for joining us on part 3 of our Preconception Health Lunch and Learn series. Through our coalition's needs assessment that was completed in 2020, we recognize that poor preconception health and health inequities are negatively affecting pregnancy and birth outcomes in our community. And in our efforts to improve preconception health of women and men locally, our community came together to provide this series of lunch and learns on topics that are related to improving preconception health. Of our 30 cases reviewed of infant and fetal deaths in our FEMUR case review team in 2020, we found that sexually transmitted diseases were one of the top 3 pre-existing health conditions found in mothers. In the cases reviewed, 10% of the mothers had a sexually transmitted disease during her pregnancy. Women who have sexually transmitted diseases during pregnancy have a higher risk of having a baby born prematurely or at a low birth weight. In today's presentation, we will learn more about sexually transmitted diseases in both men and women and how they affect pregnancy and birth outcomes. If you have any questions during the presentation, please go ahead and drop those in the chat box and we'll answer those at the end of the presentation. So welcome to our presenters today. We have 3 of them. First is Mr. Joseph Ward. He is a graduate of Florida A&M University and holds a bachelor's degree in psychology. Mr. Ward possesses over 10 years of experience in delivering academic success presentations to K-12, college, and middle-aged adults. By working in diverse venues, he has gained the experience of providing valuable life skills training to a wide variety of community members. Mr. Ward has over 10 years of experience within the field of HIV/STD prevention. Beginning as the developer and director of the Sexual Violence Prevention Program in 2009. Mr. Ward has served as a prevention training consultant, contract manager, early intervention consultant, linkage coordinator, outreach specialist, and HIV/AIDS 500/501 trainer. Welcome, Mr. Ward. With him today is Miss Elena Steeple, who is a board-certified advanced practice registered nurse practitioner in adult gerontology primary care at Neighborhood Medical Center, a local federally qualified health center where she not only works as a Ryan White Part C provider, but also a health educator and advocate, empowering a person on how to take care of his or her health, her physical, mental, and sexual health is paramount. Also with us today is Mr. Dale Harrison, who is a regional STD program manager for Area 2 in Leon County. He has been with the STD program for 30 years. His program oversees 14 counties in the area and specializes in intervening in the spread of STDs. Mr. Harrison is a graduate of Florida A&M University, Smith Chapel Bible College, and Newburgh Theological Seminary University. Mr. Harrison has always had a passion to help the whole person, and as the program manager, his true passion is preventing congenital syphilis through educating the community. Welcome to the 3 of you, and thank you for being with us today. Mr. Ward, we'll go ahead and start the conversation with you.
Okay, well, once again, thank you for having me. I'm Joseph Ward, the health educator and outreach specialist for Neighborhood Medical Center within our Ryan White HIV/AIDS prevention program. So today I'm presenting to you some of our latest HIV statistics from our Big Bend area. If you're not familiar with the world of HIV/AIDS, we call this Big Bend area, we call it Area 2B. And so that encompasses all the 8 counties of this Big Bend area. So in 2012, as far as HIV diagnosis, in the year 2020, there were 75 HIV diagnosis in the Big Bend area. So as far as AIDS diagnosis, there were 40 AIDS diagnoses within the Big Bend area in 2020. So this is giving people a look at how statistics are laid out and how we calculate our numbers. So separating the number of people who have contracted HIV from the number of people who have moved into the AIDS category. As far as adult HIV and AIDS diagnosis by sex at birth in 2020 in Area 2B, we had 73% of the males who were tested were positive for HIV, and 27% of the females who were tested were positive for HIV within the 2020. As far as AIDS diagnosis, so those are people who have HIV who transition into the AIDS category. As far as male, it was 67%. And as far as females, that was 33% of the people we were being able to keep track of during that time. Adult male HIV diagnosis rates by race or ethnicity, and this is 2020 as well. Actually, this is a graph showing the progression or the degression of HIV from 2011 to 2020. So in 2020, as far as for our white population, we had around 60 cases, 60 diagnoses. As far as for our Black population, there was around 35. As far as our Hispanic and Latino population, around 20. And for the other populations, it was more steady, more, I would say around 7, right around 7. So as far as adult female HIV diagnosis rates from 2011 to 2020, so in 2020, we can see there's a decrease and an increase. So we can see a decrease as far as the Black population, but we see an increase in the Hispanic population as far as the HIV diagnosis. So to give you an example, in 2019, the Hispanic population as far as the diagnosis was at 0. In 2020, it's almost 30. So it's about 25 to 27. As far as the Black African American, it was a slight decrease from 2019 to 2020. But this is changing how we conduct our services and changing the populations that we provide for. We would normally provide for our normal target populations will be Black MSM men who have sex with men. So from the statistics that we're able to look at now, we see a changing in our demographics. And we're seeing not only is as far as sexual contact, men having sex with men, that is no longer the riskiest form of sex somebody can have as far as HIV transmission. We see now it's heterosexual sex, so male and female. And we also are seeing a rise in certain age groups, and we see a slight decline or the numbers being steady. So we know in this area, ages 13 to 25 is usually our target population, our priority population. But now 50 plus is also our priority population because we've seen an increase of HIV rates in persons 50 plus. So once again, that changes the way we conduct our outreach. We're no longer targeting Black men who have sex with men between the ages of 13 and 24. That's just one of the priority populations. Now we're also targeting Black women, but we're also targeting Black women and Black men, but just people, period, over the age of 50, because we can, from our statistics, we see that these people are having sex, and as far as HIV specifically is being transmitted. Let me go to this next one. So adults with HIV in 2020 living in Area 2B. So, and I'll give you this by race, age group, and mode of exposure. So as far as white males, we had 320, as far as raw numbers, 320. White females, it was 80. Black males, we had 1,051 new cases. As far as women, Black women, there was 508. Hispanic and Latino, for males, there was 75. Hispanic and Latino females, there was 25. As far as the other categories, for males, there was 28. And for females, it was 17. As far as the age groups, so reinforcing what I was just saying, age groups, this has 20 to 29 is, for males is 213 cases, and for females is 47 cases. For 30 to 39, there was 314 cases, and for males and 103 cases for females. For 40 to 49, there was 287 cases for the males and 173 cases for the females. Now, 50 plus, there was 652 cases for males and 307 cases for the females. So once again, the stats are showing us how the demographics and the populations are changing who we serve. As far as modes of transmission, men who are having sex with men is still the one of the main ways of contracting or transmitting HIV outside of what I just mentioned, heterosexual sex. But for men, as far as men having sex with men in that category, it would be 897 cases. IDU, intravenous drug users, we had 82 cases for males and 58 cases for females. As far as MSM, IDU, so men who have sex with men who also use intravenous drugs, those were 69 cases. For heterosexual contact, for males, it was 407 cases. And as far as females, it was 561 cases. Transgender sexual contact for males were 8 and for females were 0. And other risk, are not specified, but other risk, there were 12 cases for males and 11 for females. So once again, these numbers are showing that during the pandemic and coming in this time after the pandemic, it really helped to reshape the landscape of how we provide services and who we're providing services to, and how we give information and how we even conduct outreach. All that has changed after the pandemic. One, us being stuck inside for a while, and two, now we're coming back out and seeing how the pandemic as well as HIV still affects our community, because it almost felt like people forgot about HIV, but our numbers are showing that HIV didn't forget about our community. So persons who receive HIV diagnosis along the HIV care continuum in 2020 for Area 2B, as far as HIV diagnosis, we had about 75 persons who received that diagnosis. Persons who were linked to care, 56 people were linked to care, 53 people were retained into care, and we had 50 people with a suppressed viral load. So that means we're finding people, we're getting those people into care. The services from Bond Community Health Center to neighborhood, to the health department, to MACA Inc., to Big Ben Cares, CarePoint, they're keeping people who we find who are HIV positive, we're keeping them into care. And not only are we keeping them in care, but with the suppressed viral load, that goes to our U=U campaign. If they're undetectable, they're untransmittable. So we're having people who are taking advantage of our services, taking advantage of care, and improving their health. So this is, for me, this is one of the main reasons why our statistics are very, very, very important, so we can pinpoint the groups of people that we need to serve and make sure we serve those people, get them the correct service, the correct information, and the correct linkage to care. Because once we get them into care, we do have a history and statistics to show that we're able to help people suppress their viral loads and reduce the number of new HIV cases that we will have in our area. Now we know this information moving into 2023, going throughout 2022, we want to make sure that we're a bit more aggressive in getting back out into our communities and serving the people, make sure that information is available and services are available. So thank you.
Thank you for that overview of data. We are going to turn the conversation over to Ms. Steeple now. And
okay, great. Thank you. It's really interesting. I guarantee you, to listen to Joe's statistics, it's very, very interesting to hear, when it comes down to HIV, because HIV just celebrated last year its 40th anniversary of being here in the United States. But I guarantee you there is probably a 150% chance that those individuals who were diagnosed with HIV, they probably had at least 1 to 2 STIs, sexually transmitted infections, in their medical history. And so my portion of the talk is discussing sexually transmitted infections and its impact on males. Now, now what I did was, there were so many sexually transmitted infections. I pulled out the two of the main ones that that I see, or that neighborhood sees in the clinic. And 9 times out of 10, if I were to speak with someone who was diagnosed or living with HIV, they'll tell you they had probably had at least one of the two of the sexually transmitted infections. So if you could advance the slide, please. Now, we all know them, either they're called STDs, or also I refer to them as sexually transmitted infections. They are very common, and now it's like millions of new infections occur every year in the United States. And sometimes what I'll hear from individuals who I have diagnosed either with one of the many STIs, they'll say, well, it's curable. The only thing I could do is I have to just either get a shot or take a pill, which adds to the logic behind that word millions. And STIs are passed definitely from person to person through vaginal, oral, and anal sex. And we all know that expectant moms continue to be engaged in sexual intercourse all throughout their pregnancy. They can also spread through intimate physical contact, like heavy petting, although this is not very common. But there's something that you'll find interesting about the first STI, the most common STI that I'll discuss. Can you advance the slide, please? That is chlamydia. It's the most sexually transmitted bacterial infection in the United States. And what a lot of people do not know, men and women, is that semen does not have to be there or be on the surface of the penis for the infection to spread. But get this, only 10% of the men develop symptoms. So what does that mean? There are 90% of the men out there who has chlamydia and they don't know. Urethritis is a common condition with mucoid or watery urethral discharge, where they will see, either you'll see like this kind of mucus kind of discharge, or even they'll have pain and discomfort when they go to urinate. Epididymis or epididymitis, with or without symptomatic urethritis, which is there's a part of the male's anatomy that becomes infected on top of having the urethra infected. And they could either have unilateral, where it's just one testicle that's causing pain, tenderness, or swelling. Now, if you really stop to think about it, how many, and this is just a question for the women, and even for those who are part of the MSM community, men who have sex with men, how many of you like look at your partners, before you engage in sexual intercourse? And if you do look, is that going to stop you if you see like a watery or like an opaque discharge coming from the penis? Or if you touch your partner and he says, oh, that's kind of sensitive and don't touch me there. I mean, how many of you are going to stop? Or are you just going to say, oh, quit playing around and then you continue on, even though your partner, your male partner, has given you all kinds of red flags. How many of you are going to stop even though that heat of the moment is still present? That's a thought. Okay, the next one. Thank you. The next popular, oh goodness gracious, lately we have been seeing this in the clinic. Oh my goodness gracious. And when I did women's health, I also did some OB at the Gaston County Health Department. I saw quite a number of pregnant women who had gonorrhea. You know, they had all the makings of being uncomfortable. But one thing about, you'll notice with chlamydia and gonorrhea, men, how it affects men is in the moment, versus women, there is something that's a little more far reaching. But for men who have gonorrhea, they'll either have a burning sensation when they go to urinate. They'll say, "Ooh, goodness gracious, what is that?" Or just like how you may have seen that kind of watery, mucousy kind of discharge from his penis. For this time, it's either a white, yellow, or greenish discharge. And this discharge is not watery. This is very thick, and you cannot mistake it for anything. They will have painful or swollen testicles, although this is less common. You're more apt to see that one painful testicle, kind of swollen testicle with chlamydia. There's discharge, there's anal itching. You know, I often think of little kids in the sandbox when they have pinworms. That's the one thing that they do. They will scratch. Well, guess what? This is not the same, okay? This is not the same. If you see your partner having anal itching, this does not make him having been with another male, but that would cause me to ask questions, because that is one of the things that is currently happening, is that men are having sex, some men are having sex with males, and then they go to their females. So if I see my male partner starting to have that itch in the back, I'm going to ask questions. Soreness, bleeding from the rectum, painful bowel movements. And one thing a lot of people don't know is that gonorrhea is becoming antibiotic resistant. So as you can see between the two lists, these are just two out of many, many, many STIs. But if you notice, men are having difficulty right at that moment. They're not having difficulty 20 years down the line, or pelvic discomfort, let's say a year or two down the line. Theirs is right there, that's happening at that moment. Okay, someone advance a slide. So in conclusion, and God knows I can talk, Joe and I can talk, and Dale can talk all day on STIs, but we're given a certain period of time in which we need to stay within, is that it's very, very important, very important. Either you abstain from sexual intercourse. Well, in the perfect world, that would be great. But if you are in a relationship with just one individual, monogamy is the best way to go. And if you're not, consistent condom use, consistent condom use. Boy, I wish I had a song or a tune I can put towards that. Joe, we need to think of a song or a tune with Mateus and Kara that we can actually come up with. Consistent condom use. Protect yourself, protect your unborn baby. That is one of the keys. And PrEP, pre-exposure prophylaxis, and that's to avoid HIV infection. That's a whole nother talk within itself, but there is medication out there that actually helps to put you in a position to avoid HIV infection. And so that's my side of the talk today. And please, if you have any questions, please wait till all the talks end, and more than happy to answer your questions. Thank you.
Thank you for that information. And we do have some questions in the chat box, but we're going to go ahead first to Mr. Harrison, who is going to present. Just bring up your slides here.
Good morning, good afternoon, everybody. What a wonderful presentation, Elena and Joe. Elena and Joe and I have been working together for a long time. Can everybody hear me? Okay. And you know, for some reason, it seems like we've been preaching the same sermon. Get to some it doesn't. But we're here today to kind of educate those on STD. And Elena, she really touched on a lot of things that I was going to talk about. I promise you I'll be brief. I can talk, you know, but I try to be a little direct. And also we have a few vague pictures that we're going to show. So we usually show some of these presentations in the middle school, high school, so they can actually see what's going on. Of course, my name is Dale Harris. I'm the STD program manager. I've been here 30 years. I started as a DIS. Various counties. We cover 14 counties all the way from Bay County to Taylor County. And the application that we have, STARS, which is a surveillance tool. Anybody that tests positive 9 times out of 10, I have it before anybody else because it comes up in our electronic lab. So if they're positive for gonorrhea, chlamydia, HIV, syphilis, I can see all that. And I also can do what we call a record search to see if it's an old case of syphilis, the case of HIV or whatever. And mostly, like Joe was saying with the HIV, you know, our job is to make sure that they are in care. But today I'm just kind of give you an overview of what's going on in Leon County. So we can go to the next slide. We can look at some of the STD or some of the things that we're doing here in Leon County. Like Elena said, STD or sexually transmitted infection that are passed through sexual contacts. We do have different types of STD, gonorrhea, chlamydia is our main STD that we see, syphilis, and of course, HIV. Here, just this week here, we saw about 4 or 5 new cases. So that kind of let my antenna up because our syphilis rates are going up like crazy. So we got some data here that we pulled, and this data is from last year. I haven't compared this year with last year, but on the next slide, we'll see what's going on here in Leon County. So when we look at our data here, we can understand here that when we look at 2021 provisional data, and I'm gonna pull it up on my screen so I can see it all. So when we look at this provisional data here, I had a chance to break down the chlamydia and the gonorrhea itself. So when we look at Leon County gonorrhea, we can see that we had a total of 3,242 cases. And you'll notice that females had 2,138 of those cases last year. 16 was unknown. So those are some of the cases that we didn't mark, whether it was male or female. But you can see right there, that's a lot of chlamydia that we see here in Leon County. And even when we talk about the gonorrhea there, we're talking about 1,483 cases of gonorrhea. And it's almost equal with the males and females. Now we have more males testing because of the new testing apparatus, which is a urine test. A few years ago, I remember when I first started, a lot of males would not come to the health department due to the invasive testing, and they did not like that. But now with the new urine test, we're able to pick up more gonorrhea and more chlamydia. And what I like about it is Elena and Joe and I, we work so close together in this business. Let's look at the HIV and the syphilis here in Leon County. The next slide. So next slide, when we look at HIV here, last year, we had a total of 40 cases of HIV and a total of 296 cases of syphilis. I remember when I first saw the incline in 2017, we had a total of 77 cases of syphilis, and all of a sudden it started increasing drastically. So now we're looking at a lot of syphilis, and we can see that syphilis and HIV, chlamydia and gonorrhea all goes together. So even with all those numbers with the chlamydia and gonorrhea, that let us know that it's a lot of unprotected sex going on in Leon County. Let's go to the next slide. Even when we look at Waukulla is a small area that we deal with. You can see that still that's 134 cases of chlamydia that was in that little bitty area there, but yet still it's still a lot because, we're 134 cases of chlamydia. Also, it's a possibility that HIV and syphilis and gonorrhea could be there. We had a total of 43 cases of gonorrhea last year in Waukulla itself. So when we look at the males and the females, you can see that the females are much higher, a little bit higher, especially in chlamydia, because we have more females coming to the health department and going to other providers. And with the new testing device, the urine test, we're actually able to pick up this gonorrhea chlamydia, which is very good. And we're able to follow up with treatment and to verify partners, because we actually do partner notification with all gonorrhea, chlamydia, 15 years and younger, and actually pregnant females also. With the syphilis, of course, we following up, we actually doing partner notification, and HIV, we do partner notification, and we work very closely with the HIV program to try to make sure they're linked to care. Let's go to the next slide. So also when we look at HIV in Waukulla, we can see that we did have 2 cases of HIV, 8 cases of syphilis, but I think our number's going to change in 2022 because of the testing. And thank God the numbers don't look like Leon County, but I think we might have a smaller increase in our outlines counties. Let's go to the next slide. Next slide, we're talking about STD and how STD can affect the fertility in a female. First of all, we noticed for a fact, and I think Elena touched on this, STDs that are left untreated can cause PID, which is pelvic inflammatory disease, which is infection in females. PID spreads from the vagina to the womb, to the fallopian tube, and all the way to also to the ovaries. And for pregnant females or females, couples that are trying to conceive or have a baby, I recommend preconception with STD testing, which is recommended for females who are trying to conceive. According to CDC, 10 to 15% of females with chlamydia will develop PID. Also, chlamydia can be the results and the fallopian tube infection with the mild or no symptoms, asymptomatic. And I think Alina kind of hit on that. Let's go to the next slide. Okay, and our next slide is STDs can affect the fertility also in males. In males, gonorrhea can cause the sperm duct to become inflamed, which is called epididymitis, which Elena hit on. Epididymitis is the inflammation of the tube at the back of the testicles that stores and carries the sperm. So it can affect the fertility of men if they go untreated. Also, we know that if it's left untreated, it can cause a male infertility through the scarring that blocks the duct and prevents sperms from entering the female during intercourse. With proper treatment, epididymitis can be cured. In our trainings, in our presentation, we let folks know the difference between being cured and actually treated. We treat HIV because there is no cure, but gonorrhea, chlamydia, we can get antibiotics and we can cure. Let's go to the next slide. Okay, our next slide here is talking about chlamydia, is which one of our most seen STDs it is. It's caused by bacteria. It can incubate from 2 to 3 weeks and can be passed on. And most of all, it is asymptomatic, especially in males. So it is asymptomatic. Let's go to the next slide. So this is what it actually looked like. Symptoms in females, which is abnormal vaginal discharge, very painful during sex, even sometimes when the urination of male, you know what I'm saying, they can get dysuria. But this is what it actually looked like. And like Elena was saying, it may be running, whitish, burning up to urination. So 9 times out of 10, you know, if you don't have sex or whatever, make sure you examine your partner very well. Let's go to the next slide. Okay, the next slide is gonorrhea. And of course, we know that gonorrhea is also one of our known STDs, which possible side effects can cause heart disease, sterility, blindness, arthritis, kidney damage, and so many more side effects. Our next slide here, gonorrhea symptom in males, which is that discharge. 9 times out of 10, a male gonna know what's going on. He'll probably see that discharge before anybody else because sometimes a female have a normal discharge anyway, but 9 times out of 10, usually it's thick, milky white, or greenish. And of course, most males I talk to do partner notification. Reason they came to the health department because they had what we call dysuria, which is the burning of the urination once they go use the bathroom. So most of the time that brings them to the health department. Next slide. So this is symptoms in the female. Painful urination, abnormal uretine bleeding, pain during sex, and like we all say, it can be asymptomatic. Our next slide. Next slide is testing and treatment for gonorrhea and chlamydia, easily detected by a simple lab test, easily cured with antibiotics. Any damage to the body cannot be repaired, easily cured with antibiotics. Any damage to the body cannot be repaired. Let's go to the next slide. We're going to talk about syphilis, primary syphilis. Now, syphilis is something that we really need to start paying attention to because, like I said, syphilis is on the uprise. I mean, we had about 6, 7, 8, maybe 9 cases walked in this week. Most of them had signs and symptoms. Primary syphilis occurs in males and females. That pains the store. Some females may not notice it because if it's on the uterus or whatever, they'll never see it. So most males will know a penis on, a lesion on the penis there. So like I said, it can be located on the penis, anus, or in the direct contact. This stage is very contagious. The sore might last 1 to 5 weeks and it'll go away without treatment itself. And a person can pass it on. Treatment is usually 2.4 benzothane, which is a penicillin. Very important that we know how to diagnose our syphilis too, because with this here, they only need 1 treatment. Let's go to our next slide. Okay, our next slide, secondary. Also, I want to tell you with the primary syphilis also, so a person can actually walk in with a penile lesion, take a blood test, and have a negative RPR, only because it takes time for the spirochetes to actually get into the bloodstream. So we bring them back and we test, and if we see a lesion, we go ahead and treat. Confirmatory test is very important also to make sure that we don't have a biological false positive, because we're seeing a lot of pregnant females that come in from providers that test positive for syphilis, but their biological, their confirmatory test, non-treponema test is coming back negative. So we're seeing a lot of that. Secondary syphilis, which is also considered as early syphilis, may include a skin rash, fever, swollen lymph node glands, headache, hair loss, muscle aches, skin rash can be in the palm or plantar. Matter of fact, we saw 3 cases this week that walked into the health department with palmar plantars, and it can be on any part of the body. Last year, we had 9 congenital babies that was born here in Leon County, and we'll talk about congenital, but it's very important that we be able to acknowledge these stages of syphilis. The rash may last 2 to 4 weeks. Every time we come in and do partner notification to do an interview, these are some of the questions that we want to ask, because we want to be able to know how to diagnose that disease. And when we can diagnose, we know how to treat it, because if it's primary or secondary, like we said, treatment can be, one treatment, 2.4 million units of benzathine, which is the penicillin. So this is what secondary syphilis look like. And believe it or not, like we said, everybody do not have the signs and symptoms, but with signs and symptoms, it helps us to diagnose the stage of that syphilis, and also help us with our interview period, because with our interview period, we can go up to 8 months. So anybody who had sex with that person within 8 months, we definitely treat. So this is what secondary syphilis look like. Let's look at the next slide. Okay, so the next slide is common symptom of late stage syphilis. And with this here, late stage symptoms can include paralysis, insanity, blindness, damage to the knee joints, personality change. We all have personality change, so that don't mean a person has syphilis. I say that all the time in my presentation. Impotency and all these other symptoms of late syphilis. Late syphilis is unknown duration. So person walking to the health department, we draw blood, they are 1 to 128 with a positive EIA. I don't have any history of that person in my system. I don't know how long they had it. Nobody named them, so we're going to treat them times 3. We're going to give them 7.2 of benzathines, because we don't know. In other words, we're trying to prevent neurosyphilis. So with latent syphilis, we definitely treat times 3. Let's go to the next slide. Next slide is the latent syphilis here. And this is a diagram here of what we're talking about. Latent syphilis is a hidden stage of period when there is no visible signs or symptoms of syphilis. Early syphilis is latent syphilis, where infection occurred within 12 months. So, for example, person comes to the health department, January, negative RPR, they come back in August, 1 to 128, positive FTA, positive. So therefore, I know that's early syphilis. I can prove that that person didn't have syphilis or had syphilis within the year. Anything I can't prove within the year, like I said, if a person don't have a history or whatever, it changed their diagnosis and it changed their treatment. You can see right there, early syphilis, less than 12 months, get 2.4 units of bicillin. Late syphilis, anything more than a year or whatever, we treat 7.2 million units, because, like I said, we don't want to have what we call neurosyphilis. So therefore, we treat adequately. Let's go to the next slide. Okay, next slide is my big is my passion. A mother can pass congenital syphilis on to a child. Dr. Rush and myself, we went out a couple of weeks ago, and we had a presentation there with North Florida Women Care, and we had a chance to talk to about 22 OBGYNs and to let them know the importance of doing the blood work on pregnant females. And pregnant females, they definitely need the blood work done at the initial visit, 28 to 32 weeks, and definitely at birth. And what it does, if they can draw that blood in that time period, it gives us a chance to actually treat the mother adequately. We catch, pregnant female pregnant in the first trimester. They give us a chance to treat it. If it's latent syphilis, guess what? We can treat times 3. She can carry the baby for 30 days. And if she carried the baby for 30 days, we can rule that out as congenital syphilis. Also, let's go to the next slide. Also, when we look at congenital syphilis, we know that congenital syphilis is very severe. It's disabling, and often it's life-threatening infection. seen in infants. A pregnant mother who has syphilis can spread the disease through the placenta onto the unborn child. And this is where, we really, really get involved with pregnant females. So we got a pregnant female who tests positive for syphilis. We drop everything we do and we follow up with that pregnant female. We want to know if she get prenatal care. We want to know if she have a history of syphilis because, like I said, if you had syphilis one time, 9 times out of 10, it show back up in your blood work. So it's a way to go into our system and make sure that it's not a new infection. So what we try to do, we try to make sure we do a record search and make sure that the mother is an old case of syphilis. If she's a new case of syphilis, we start treatment immediately. And if she, matter of fact, we had 2 to walk in last month that had primary syphilis, and one had secondary syphilis. So we was able to treat, and new CDC protocol said we treat ×2 instead of ×3 to make sure that the baby's okay. So last year we had 9 cases of congenital syphilis, which was not acceptable at all. When a female go and have 15 visits at her OBGYN and no blood was ever drawn, that's not acceptable at all. So when we see a pregnant female, the first thing we do, we make sure we adequately treat, and if she has syphilis, we want to do everything we can to prevent a congenital baby. Let's go to the next slide. And of course, it's the same thing here. Congenital syphilis can cause a miscarriage, stillbirth, prematurity, and death shortly after birth. So it's very, very, very important that we stay on top of it, and we look at congenital syphilis as our highest priority in our program. Let's go to the next slide. Testing the pregnant females, and this is the protocol 64D 3.042, where we was talking about pregnant females should be tested on her first prenatal visit, 28 to 32 weeks, and at delivery. And 28 to 32 weeks, that give me a chance to treat her ×3, and she carried the baby for 30 days after the first treatment. And those treatments have to be consistent. So according to the CDC guidelines, they have to be within 7 days. We could probably squeeze 8, but we rather do within 7 days to prevent congenital syphilis. Let's go to the next slide. Okay, this is a treatment guideline here. And of course, we do have an updated treatment guideline, which is 2021. And some things did change there, but we recommend all the providers to go to the new guidelines and use the guideline accordingly. Next. Okay, I'm gonna pass by the HIV and skip on because Joe did the HIV. So we can go to the next slide. Joe did all the HIV, and I said I wasn't gonna do the HIV because Joe did it. Let's keep going. This is what we're doing in Leon County here. We increased testing in the community through our CBOs. Even at Leon County Jail, we just we're part of a grant that just came down, and we are testing all childbearing females when they first come in 20 to 48 hours. And we just got that program implemented. So the nurses over there at the Leon County Jail is working very, very close. We collaborate and meet with the local OBGYN quarterly, syphilis congenital case reviews. When we do have the case reviews, educate provider with syphilis update presentations, what we're doing now. STD HIV presentation in middle school, high school students. Last year, we had a chance to reach about 2,000 students. And in 2019, we kicked off our 2019 Syphilis Coalition. And I think, Chris, this way you was a part of last year and the year before. And Sandy, I think he was there also. Joe and everybody else was there. So that was good for the community. Let's go to the next slide. Next slide. This is my contact information. So if anybody needs to reach Dale, they more than welcome. And today is STD Awareness Month. Joe and I, we plan to come together April 29th there at Macomb Street. That's the time saver there right below the Frenchtown area. And think we're gonna do what, 12 to 3 or 1 to 3, something like that. And if anybody want to come out and be a part of that, they're more than welcome. Our job is to make sure we offer rapid syphilis tests, HIV and syphilis, and also be able to give all information concerning STDs and HIV. At this time, this concludes my presentation. I didn't want to run it too long or whatever, so forgive me if I went over time, but I'm willing to answer any questions, and thank Elena, and we thank Joe for also being a part of this presentation.
That was perfect. Thank you. Simone, do we have any questions in the chat box? You're on mute, Simone.
Yes, we had one person asking, Joe Ward, what time frame did you gather your data?
Well, that was to Dr. Adam. I did answer that for him, but I'll let you all know. So the data that I have, the time frame was from between 2011 and 2020, and this was data collected by the Florida Department of Health.
Okay. And then we had two more questions. What is the difference between HIV and syphilis? And what is the prevention of gonorrhea?
I'll take the first part, and I guess Ms. Steeple will take the second one. So HIV, what was the HIV and syphilis? What was the difference?
Yes.
Okay, so syphilis is a bacterial infection. That's the basics of it. Syphilis is a bacterial infection that can't be cured. HIV is a viral infection that can be treated. So because it's viral and it's considered a blood-borne pathogen. So think about HIV as a virus that lives, it's born, it lives, and it dies in the bloodstream. And it can only be treated. HIV the levels of it can be suppressed. If going untreated, the levels of it could rise and rise and rise. But syphilis is a bacterial infection that can't be cured. Now, syphilis going untreated could really ravage the body in a quicker time. Well, it could ravage the body, may not in a quicker time than HIV, about around the same time frame. But just the basics of those two, think about a bacterial infection in syphilis that can be cured, and a viral infection in HIV that can be treated and managed.
Thank you.
You're on mute, Ms. Steeple.
And how can, HIV, syphilis, gonorrhea, all the other numerous STIs be combated is by abstinence, monogamy, consistent condom use. I tell you, I'm going to come up with a song that everybody is going to sing, and they're going to be singing it when they're with their partners. It's going to be like those little earworms, that's going to be playing in your head. Consistent condom use. Those are, and PrEP, the pre-exposure prophylaxis, by taking either the medication Truvada or Descovy, which are actually two actual HIV medications. Those are the ways to prevent becoming infected, either abstaining from sex, monogamy, consistent condom use, PrEP. Those are your surefire ways of avoiding STI infection.
Thank you. And I think that ends the comments in the chat, but if anyone wants to open up their mic and ask a question, you can.
Okay, no questions. All right, well, that concludes today's Lunch and Learn. I want to thank you all for joining us today. Our next Lunch and Learn will be on May 6th, where we are going to be talking about preconception health and mental health. Our presenter is Lola Brognano, who will be joining us for that conversation. Mr. Harrison, Mr. Ward, Ms. Steeple, thank you very much for presenting today and for sharing the information with us.
Our pleasure.
Right. Thank you, everyone, for joining us. Have a wonderful weekend.